Thank you, everybody, for being here. Again, as a reminder, please submit all the questions in the Q&A box. So I'll get started with Dr. Puto. Um, and I want to ask you, what physical exam skills are best to work on before starting clinicals?
I just want to say thank you everyone for being here. So excited to meet with you all and discuss making transitions. And I would say as a part of that, I think personally the greatest thing to focus on when it comes to developing your clinical exam skills are to focus on the basic screening neurological exam. So this is the thing that's going to be most applicable to seeing any patient, that having a good grasp on before you get to rotation can be somewhat helpful. So, having a systematic approach of examining mental status, cranial nerves, strength and sensation and reflexes, coordination and gait are very important. And so I think having some understanding of that before you arrive is kind of critical. And once you're on rotation, you want to develop reliable exam skills and, get a good sense of, how to identify problems and in a reliable fashion, and that the information that you're providing to your residents and your attendings are accurate. And part of that, I think, is working with your residents and your attendings, have them observe you perform the neurological exam so that they can give you in-the-moment feedback. I think a lot of people do the exams and they report it and sometimes get, months or even years down the road thinking that they've done it the correct way and perhaps it should have been done differently. And a lot of that can be caught very early on by just asking your residents and attendings to observe you directly. And then I think, once you've kind of graduated from, doing the screening neurological exam, I think it's important to start thinking about localization and, what makes sense for localization. So sometimes when people start out, they may have disparate, exam findings. And so sometimes you want to think about, well, does this make sense for the overall exam? So if somebody has weakness, do they also have, problems with tone, or do you see any problems with fasciculations, or do you have elevated reflexes? So multiple different data points that can suggest that there's something wrong with a particular part of the nervous system. And then finally, I would just say, just think a little bit, whenever somebody presents with a chief complaint of, say, vision, maybe you want to do more than just visual fields, test their visual acuity, color vision. And so just put some thought into what is the chief complaint and interrogate that specific, complaint in greater detail. And so that's kind of, my advice in transitioning.
Yeah, thank you. And I'll just tag on to that and ask Dr. Rojas Soto, how do you think students should prepare best for the neurology rotation? You may have some additional things to add.
Yes, thank you so much. And it's good to be here with you guys tonight. And, I think that depends very much on how long ago have the student gone through the neuroscience course, right? Some schools are third year rotation, some others are 4-year. But I think it's very important to have very fresh in your mind neuroanatomy, neurophysiology, and a little bit of the pathological process. That really gives you a context and prepare your mind to start absorbing all that clinical information and putting together the examination, the information that you had from before in your preclinical years, and put it together to formulate a diagnosis. So it really helps you localizing lesions, understanding why are you seeing this symptom in the outside, and put it in the nervous system. So I think that's a fundamental part of getting ready for your neurological clerkship. It will help you using more that clinical experience that you will get during your clerkship.
Very good, thank you. And so, Dr. Lendaris, my question to you is, what are some examples of bread and butter cases for neurology that may be beneficial to brush up on before, beginning a rotation?
Yeah, thank you. That's a great question, and thank you for having me. I think something that you would be surprised is that headache is one of our most common complaints in neurology. And so understanding what a headache, the primary headache disorders versus the secondary headache disorders, and really understanding how to frame questions so that you'll start leaning in one direction toward another. Another key common is the dizziness. A dizzy patient, a lot of dizzy patients on neurology and our consult services. And sometimes it'll lead you to a maneuver, the Dix-Hallpike and an Epley, to resolve it in the peripheral system. Or sometimes it may be a really subtle sign of a posterior circulation stroke. So peripheral system, central system. So really understanding dizziness and how you might approach a patient that way. I think someone mentioned vision, right? It's Dr. Hutto mentioned vision. I think exactly, like to understand the retrobulbar, like behind the retina and within the globe, what is the vision pathway and the process? We see a lot of vision changes as well, and you'll have people complain about blurriness or some vague complaints. And if you have an understanding of some fundamentals to localize, just like my colleagues were saying, that'll help guide your questioning as well in your exam. So I would say that those are the key things. And then we see seizures and strokes are common in the inpatient setting where most of you will be doing your rotation. And if you're fortunate to have like that outpatient experience, that's where you get to see some of our subspecialties of movement disorders and neuro-oncology, et cetera. So MS clinics. So that's more of the specialized area, but the bread and butter, I would say, to stick on to some of those earlier topics I mentioned.
Yeah, thank you. And if I can just summarize and put this together and answer one of the questions is, is it suggested to study specific preclinical information before each rotation? And obviously, you're going to be busy with another rotation, so I don't know, if you're going to have the time to brush up. But for me, I think if a medical student can get a good history and, as one of our faculty said, learn how to do a clinical exam, I think that would be, really helpful. And, as Dr. Lendaris said, there are some bread and butter cases, what gets admitted, on the hospital service. So would be good to you. I mean, obviously you don't want to read everything. You won't have the time for it. So history and physical exams, some bread and butter stuff would be good. And I'm also going to answer one more question, which is, how do you work your way through possible imposter syndrome? And the way I look at it is that, nobody is going to know everything. Even we don't know everything. I think it is important to recognize that you're here to learn. The attendings are not here to judge you, but to really help you, learn and grow. And so it's important that if you can identify what your best attributes and strengths are that you bring to the rotation and you play on them. But at the same time, look at, I don't like to think of anything as deficiencies, but rather what are some opportunities for growth? And we all have them. And essentially you identify those opportunities for growth and keep working on trying to improvise there. I think that would be, I don't know if faculty have anything else to add about imposter syndrome.
I just want to say that we all have imposter syndrome every stage of the way. So when I started as a junior faculty member, I can promise you my first day in a tertiary hospital as the quote unquote attending, I felt very much like imposter syndrome. I thought nobody would listen to anything I had to say because I was a resident here as well. And it's like, one day you're a resident, the next day you're the attending. So just recognize like we're all dealing with that together. It's a natural part of the evolution as you sort of ascend the ladder in training and experience.
Yes, very good. And I came here, to be chief of neurology at a new medical school. And for a while, I was definitely like, hope I know all the things that I need to know to be able to do this job. But, you just get in the groove and kind of, like they say, you fake it till you make it. I think that would be helpful. All right, very good, guys. So let's talk about, what happens like during clinicals. So, Dr. Lendaris, my question to you is, how can students manage information they learn in clinicals so that it can be retained in, in organized fashion, if that's possible?
Thanks. So you're asking someone who's an ultra organizer. And so what I would suggest, and not just for neurology, but all your clerkships, I personally started like a OneNote notebook that you can use on your iPhone, your iPad, your desktop. And you just start building chapters. So you can build a neurology chapter, and then it could be stroke, it could be dizzy, you can make little topics for yourself and little pearls that you hear on rounds, then you put that in there. Then you do your UWorld questions, you do your QBank questions, and there's topics that you're learning, keep putting them in there so you can kind of stay organized by topics, right? You'll also find, I think, just going through med school, you'll have someone who has that a chief concern that may be not just neurologic, but other disorders. So you have to think of a differential. And so you may want to categorize things like abdominal pain or, tingling fingers. That could help you too. I think another thing that I like to do is whether you're an outpatient or you're an inpatient, there's your encounter with the patient. What has happened before? What's the chief concern? What's the story? My exam, some objective data, and then how do I synthesize this? That's your organization, whether you're outpatient or inpatient. And the other couple of key things just to do, whenever you hear a term, an acronym, whatever it is on rounds, write it down, make a note to yourself, look it up. If it's not the appropriate time to ask on round, you don't want to stop during that moment. I think that that's worthwhile too.
Yes, thank you. And so over to Dr. Hutto. How can students best prepare themselves to advocate for their learning in the clinical environment during the collection?
So I would say that, the majority of the people that you're working with are very interested in your education. And so I think this question is a little bit twofold. And I would say the first part is, you should feel like empowered or encouraged to speak up and ask questions whenever there's something that you don't quite get. So yeah, if it's the acronym that you don't understand, or if you don't understand, how we arrived at a particular localization or why our differential was composed of what it was, you should feel encouraged to ask questions about that. Maybe it's not right in the moment to interrupt the flow of everything, but keep track of those things and make sure to ask. I think most of the neurologists that you will run into are just very excited that you're there, and when you're excited, they're excited, and they're just really happy to teach. And then I think that's sort of the basic part. But I will say that the flip side of it is, I think there are two styles to learning in the rotation. And I think one part is potentially being passive, so you can kind of take what is given and sort of what is expected, or you can take a more active role. And so some of those students that I feel really get the most out of the rotation come ready and eager, and they have some things that they're very interested in learning. And they express that to the residents and the attending. So if it's somebody that really wants to learn how to do lumbar punctures, maybe they don't want to be a neurologist, but they want to be a surgeon or a proceduralist, or I don't know, maybe they want to go into OB-GYN and that's a transferable skill, or anesthesia or something like that, then they'll speak up and let us know. And so I think, self-directed, learning and being active and saying like, these are the things that I want to focus on, oftentimes will help people grow the fastest. And so feel free to bring that up when you're on rotation and let people know. I think neurologists will definitely be just interested to hear that you're interested in neurology, and then lots of learning will follow.
Yes, very good. And just to tag on to that, my next question to you again is what makes students stand out during clinical rotations?
So I think, the thing that really stands out in my mind is, or the thing that tends to be the most memorable, is when students really rise to the challenge and are eager to see patients, and sometimes even taking on the ones that seem a little bit tough or maybe outside of the sort of routine cases. And I think also that may pay ultimate dividends if you're interested in a letter of recommendation as a APD. The letters that I find that are the very best are the ones that tell me specifically about a time when the student was really stellar. And so, really invest in your patients and dive in. And so some of the things that I'm thinking about are, someone who has a new diagnosis of MS that has radically changed their lives. I remember a student spent extra time with them discussing what their DMT options were going to be when they arrived in clinic. So that way they could get started on a medication, expeditiously. And they knew about the drug options. They knew about the adverse effects and the pros and cons of each drug. And I really thought that they took it to the extra degree. And that was also a way to demonstrate, how much care and empathy that they had for the patient, what they were learning about. And then we had another student, provide a patient with a new diagnosis of ALS with services that they would need when they went home. So this person needed a Trilogy device, and they needed a cough assist device, and they needed to be connected to the ALS multidisciplinary clinic. And this student really just took it on and did it. And so I think the basic bottom line here is I think you're really much more capable of doing things than you might anticipate when you show up to a new service, a new organ system, and a totally new team that you may not be familiar with. But those are some of the things that really, stand out in my mind that I oftentimes remember very fondly, later on.
Thank you. And so Dr. Rohan Soto, how should we modify our learning techniques to do better in the wards? Do you have any suggestions?
Yeah, I think that's a very interesting question, and I as an educator, I think that's a very specific part when we see medical students struggling, shifting the mindset in from being a classroom learner from an actual learning environment in what you're expected to perform. And so we as clinicians and clinician educators hope that you use all that information that you have in your mind and learn how to use it to apply it on your patients. So when you're in a classroom, you read about pathology, and then you process that information, and then you might interiorize it, and then understand it, and that's how far it goes in the classroom. But when you're in the wards, right, we hope that you do the same, but you read about your case or about your pathology, then you understand the process, learn it, and actually use that information to apply it on your patient. So learning how to ask the right questions to understand the symptoms that you're seeing in your patient, the examination findings that you are actually that jumping in your eyes, and put it together with that information that you acquired from the book is the most important thing. So here is where questions to your preceptors are very critical, right? What Dr. Huda was saying, don't be afraid of asking the questions when you don't understand the process that we follow to come up with a diagnosis. Or why is it this finding is different from these other patient that had the same pathology, and it looks like the lesion is the same location. So how we can do that fine tuning on making that differences. So asking the right questions in the right moment or in the moment to understand the process of our diagnosis making is fundamental for this learning.
Thank you. And Dr. Landaris, how do students ensure that they see varied practice settings?
So I think this can be a challenge because it varies from institution from institution. And some are going to have more in-house opportunities for outpatient practice. So I would say what you would start with and what your options are for where your rotations or your lotteries are for clerkship. So if you're thinking maybe you're interested in neurology and you want to see more of the inpatient setting, then at a particular campus, or that there's more of a comprehensive center, maybe that's where you start. If you know that there is less volume at a certain campus or location, then that's maybe something that you want to not tend to go to, because more exposure is going to be more clinical experience and more chance to interact with people with different neurologic disorders. And then I would say, don't forget your fourth year. And if possible, plan early. If your institution didn't have an outpatient that you can rotate to on an elective, maybe that's where you look for away opportunities. And I would also, don't forget to come explore the AAN and just explore resources through AAN. I think that's, if you're watching this, then you're already on the right track because you found it. But I think that can help you as well.
Yes, thank you so much. So Dr. Hattu, what type of a clinical scenario do you think can only truly be understood in a hands-on environment?
So I kind of think most of them in neurology actually, but I guess I have a good example. I will admit, so when I was a PGY2, my very first 24 hours of being a PGY2 was being a night float resident. And I remember presenting my cases to the team the following morning, and I just kind of left dumbfounded because I was like, how did they, arrive at all these conclusions or say all these things? And then I just left thinking that, you just need experience to be a good neurologist. But I think, and so be encouraged by that. If you show up and you think you've read all of this stuff and things just seem different when you show up, it just does take, it's like an apprenticeship, and that's the important part about residency. But I think one thing in particular I think about is dizziness. I work in the hospital, and we get a lot of dizzy consults. And so, that if you read about dizziness, you think you have a good understanding of what makes sense for dizziness. You're supposed to divide it up into, is it continuous or intermittent? What kind of triggers or precipitates it? What might make it better? Are there any associated, neurologic signs or symptoms? And so the one thing that I've learned is, the history has to be really precisely ironed out. And oftentimes people will say things that aren't exactly the truth of the situation. And so learning how to ask questions the proper way for dizziness to get to the right answer is very important. So the patient with BPPV will oftentimes say that my dizziness is continuous. What they mean by that is they have continuous intermittent episodes of dizziness. And so if you don't dive into like, okay, is this truly every second, that you're dizzy? Or is it, you're dizzy for a minute at a time and you've learned to hold your head still and then you're fine. And then you move your head again and you get it. And then you stop moving and it goes away. They may say that it's continuous until you ask some of those follow-up questions. And a lot of that is just learning through watching your resident or your attending ask those questions. But the exam maneuvers are also very challenging to perform properly. I think especially in regards to Dix-Hallpike, when you see your first patient who has a lot of degenerative disc disease and can't lie back and turn their head all the way and you can't extend their neck over the edge of the bed, so like learning how to do it properly by watching others, I think is very critical. And the same can be said, for the hints, exam techniques to try to identify, is it a central peripheral cause? Just watching people look for nystagmus, do a head impulse, and look for vertical skew deviation is something that's kind of learned while observing others and practicing it in front of people who have good experience with it. So I think dizziness in general, the approach to dizziness is a very hands-on learning experience.
And I think we all would, those of us who are neurologists would agree with that. Okay, so moving on to the topic of preparing for residency. So Dr. Rojas Soto, what are strategies to secure a neurology residency for a DO student without a required rotation?
Yeah, I have to say first that it's very sad that there still exist, schools that train physicians and MDs and DOs that do not have neurology as one of the core clerkships. So that's the first thing that I have to say. Secondly, so if your school doesn't really have the opportunity for you to get a rotation in neurology, it is very important that you seek out as an elective. Not only because it's a good exposure for you and you can get in touch with neurologists that can give you career advice, and then you get exposure to the field that you're interested in, but also because you can get to see the patients that you're going to be caring for and really understand if this is a field for you. Our patients are a little different than all the regular medicine patients. So I think it's important for DO students and the students like don't have the option to rotate in their schools to seek out. There are many other schools that actually accepts rotating medical students, and send an email. Don't be afraid to go into the website, go through the AN and understand who is clerkship directors, and send them an email and ask for the opportunity to have a rotation, and that can help a lot.
Yes, very much. So one of the examples I can give you is we are a new program and we are interviewing applicants for a PGY2 position. And we created a really nice website, and we have specifically said there that we are a PGY2 advanced program. So you will need to have done a PGY1 position before or should be enrolled in it right now. And, we will be becoming a categorical program in 2027. And in spite of that, I at least had 20-30% of people that applied who had never had a PGY1 position. And so it's a really wrong message, because it tells me that you haven't done your research. You didn't take the time to go read our residency website, right? So I think that, while you're preparing for residency, I agree with, Dr. Ross Soto that you really have to, read up and learn the information and know what faculty are doing. And, sometimes you even get a itinerary with the names of people who are going to interview you, and perhaps you study a little bit about them so that you're able to have a bi-directional conversation, not just, them asking you questions, right? So, and so to segue into, how do international medical graduate students become competitive applicants for neurology residency program, Dr. Hoto?
Yeah, so I think, Dr. Chitnis and Dr. Rojas Soto has kind of, a lot of the same principles apply, I believe, when it comes to international medical graduates. I would say the particular one to focus on is probably, well, at least in my opinion, I'm curious what other people think, is U.S. clinical experience. So I do like to see that, people have kind of come over, they've gotten a feel for what the U.S. healthcare system is like, for the better, for the worse. And what did they think about it, and how did it compare to what it might have been like in their home country? And then what did people say about how they did while they were on rotation there? So I find that information to be most valuable, and that's oftentimes the things that I'm talking to some of the applicants about when I'm meeting with them. But I would otherwise just say, I think a lot of the general advice about being a well-rounded candidate is important. And so you think a lot about the experiences that you're working on building as you're a medical student. That usually starts early in medical school, so you want to kind of identify the things that you're interested in and work on those programs before August of 2024 when you apply in September 2024. And so I think working on the experiences that matter to you, and also that they're meaningful to you, not just in the sense of doing them to be doing them, but find something that you're passionate about. That's actually really fun to talk to somebody about during an interview, to learn kind of what makes them tick and what's their passion behind things, and how might that be very useful to them when they're a resident. And so I would say, do things, because you have a true passion behind it, maybe not necessarily because of productivity. And it's really interesting, I think, sometimes to see what sort of portfolios people have put together, and, what's kind of the common theme behind it all. And so I would say, put a little bit of thought into kind of your strategy before you get to the point where you need to apply, and focus on like your strengths and your passions would likely help you stand out.
Yes, definitely. And I can also add a couple of things, things, not to do. So, for example, you want to make sure that you know your CV very well when you show up for the interview. And if you've written a paper on a topic, make sure you review that, because the worst thing that can happen is that, the attending asks you something from your application and you don't remember or you don't know. I think that's, becomes quite a bit of a problem. Of course, I can add that getting good, USMLE scores, because some programs have cutoffs for scores. So getting good, working hard to get good USMLE scores, I think would be important. But I completely agree that the US clinical experience is important. Familiarity with the electronic medical record system is important. Knowing typing is important. All of these things, I think, really matter. Of course, if you had, some people are very, very, strategic. They get a postdoctoral fellowship, they're doing research, they're writing papers. So there's so many, different ways in which you can be competitive. So let's talk about, so I've heard some clinicians say that the clinical practice is different from bookish knowledge. Do you agree, Dr. Rojas Soto?
I do, actually. I think there is something that I tell my residents and my medical students, is that when you're in a clinical setting, what I want you to listen is to that very educated gut feeling, right? So you're using all the knowledge you have, and when you're making a clinical diagnosis and a decision to treat your patient, but not every single patient is exactly the same as the other. And there are little subtle things that makes you make a decision as to, I'm a stroke neurologist, so why am I going to give this patient aspirin or Plavix instead of aspirin? Those tiny little things. And that is a gut feeling, right? That I have educated for the 25 years that I have under my belt of education. So it is different, but you can be a good clinician if you do not read, if you're not a bookish person, if you don't continue educating yourself. The field has changed so much that if you're not bookish, then you cannot continue to have that educated gut feeling and making those decisions on the fly that makes a little difference of a practice when you're a clinician.
Dr. Hutto, how do you identify the right kind of person to write a letter of recommendation for the candidate?
I think a lot about this. It's the time of the year, I think, for interviews, and we're in the thick of interview season and reading through letters. And, I think the thing that stands out the most is that the person has chosen someone that actually knows them very well. And so I would say, stay away from choosing someone just because of their name or their notoriety or their connections or those sorts of things. Choose somebody who actually knows you, because I'm trying to decide if I want to, offer essentially a job to you, and not necessarily that other person. And so I want to get to know, you. And so the people who know you really well are the people who are most likely to write you a good letter. And I do think that, coming from people who have evaluated you clinically is very important. People who can write, detailed statements about how good you were in this way and that way. I think in general, a lot of people will have letters of recommendation that are quote unquote good, but oftentimes they will be good in kind of a vague way. And so when letter writers who know you really well and can recall that experience will say, oh, they really, went the extra mile, or they kind of cracked this case, or, we had a person come in encephalopathic and they made a point to call the family and figure out that key detail that, gave us the underlying etiology. Those things really stand out, at least to me, when I'm reviewing applications. And so I would definitely say pick somebody who knows you well. And the other side of it is make sure you choose somebody who has time to write you a good letter. So if you choose an overly busy person, sometimes, those other things take precedence, and then the letter gets done at the last minute. And, that's the quality of the letter that you can get. So just have some awareness of that. Make sure that person is very interested and invested in your future. And so just put a little bit of care or thought into who you ask to write your letters.
Yes, I completely agree. And I really cannot emphasize how important it is to get your letters on time, because, we're reviewing these applications, and if they're missing a letter, they're missing some scores, those applications just get put on the back burner, and, you may not get selected because if the program is basically filled and you haven't sent yours. So talking to the letter writers way ahead of time, giving them a ETA on by what time I, need for you to do this, I think, is very important. Dr. Ras Soto, what are main pieces of advice that you would give to a medical student that's aspiring to pursue a career in neurology?
Yeah, I believe this applies to most specialty, but for neurology, I think intellectual curiosity is something that you need to maintain, right? Our field has changed and is going to continue to change so fast. I can tell you that when I graduated from med school, there were many diseases that we have these days that did not exist when I did. The symptoms were there. We knew that we needed to compassionately treat our patients, but we didn't really understand what was happening to them. And technology had helped us understand them better. So if you don't maintain that curiosity and don't keep reading, stop reading once you're in practice, then you're gonna fall behind and you won't be a good neurologist. The other thing that I think is very important is compassion. Unfortunately, the kind of pathologies that we do treat give our patients very difficult disabilities, right? Devastating disabilities. And it's not just treating the patient itself and in the acute setting, is understanding how does the disability that now they're facing impacts their daily life, and how do they have to adapt to this new situation. That will give your patients that comfort and that understanding that you are there to support them and help them walk through their pathology, all the stages of the pathological disease. So I think those are the two very important things for me that stands out when you are treating patients with neurological conditions. And your patients will be very grateful to you when you can cure them, but when you can, but you understand that what they're facing in their daily life, it is important. So
I can answer this question, additional general career guidance. Obviously, everybody has to work hard, but I think it's also important to be strategic. I think, for example, when you are on clinical rotations, you could essentially meet up with the attending right at the beginning and ask them, what are your expectations? How do you expect for me, to present my cases? What are specific things? Talking about documentation, perhaps, talk to them about reviewing a couple of your notes and giving you some feedback. That sends the message to the attending that you're truly interested. I think feedback is really important. I think we all hear feedback because we don't want to hear something negative. But as I said right at the beginning, that I don't really think of, anybody having deficiencies. I always think of it, as opportunities for doing better and for improvisation. So I think it's really important, a eager beaver, like they say, always catches a worm. So being an eager beaver is really important. Being prepared is really important because, there is nothing called luck. Luck is essentially preparation meeting opportunity. And so just having that initiative, I think, is very important. Perhaps, we can talk, we still have some time, so perhaps we can talk about, you know, some questions that I may have. So I don't know whether any of you guys are program directors, but what do you specifically do with the applications where an applicant has sent you a signal? Is there anything that you do specifically with those applications?
I'm in APD, so I guess I can start. If someone signal, I think signals are important. Signal is your way to tell the program that you're very interested in them. And there are every year we get hundreds of applications, and sometimes it's hard to figure out who is interested particularly in your program. And I think this day and age, especially since interviews are virtual, or at least they are in the majority of places, it's very easy to interview anywhere, essentially, all across the country. And so that's an easy thing to send an application. It's an easy thing to interview because you can do that from your living room essentially these days. And so there's I don't know, for lack of a better term, there's a little bit of or less skin in the game. And so I think signals are important because you only have so many, and everybody knows that. And so it's a good sign of saying like, hey, I'm very interested in your program. And so I will say or admit that we really take a hard look at people who have signaled us. We're very careful with the folks who submit a signal to our program because we know that they're particularly interested in us for whatever the reason is, and maybe that means that there's a higher likelihood that they're going to end up coming here. And so I think signals are particularly important.
I also want to ask, are there any interview tips that you would specifically, give the applicants? Like, the day of the interview, is there anything, Dr. Hutto, that you specifically looking for that would be helpful?
Yeah, I think it's, so Dr. Chitnis kind of alluded to this a little bit earlier, but do your homework. I think if you're going to interview at a program, a lot of programs will publish information about, the structure of the program, the curriculum, various aspects of the program, and certain things that are a major plus or certain things that actually you may find you don't like. And so I think, when it comes to the moment where you have an opportunity to ask questions or even to weave into your answer what it is that you're particularly, liking about the program, I think someone who's done their homework, really has a leg up. So I think when it comes to interviewing, like, think about that. And so there's that one piece of the program, but there's also the piece about oftentimes you'll be told who you're going to interview with. And sometimes it does make for a little bit of an easier, natural, free-flowing conversation if you have an understanding of who those people are. And who knows, maybe through your research about them, oftentimes you can read on the website what their interests are. You can even figure out on PubMed, what they've published in. And so you get a good sense of what they're interested in neurologically and scientifically. That can make for a really easy conversation. And sometimes you can figure out like how your interests are mutual. And that makes for a good conversation. And I think, Dr. Chitnis kind of noted that a little bit earlier.
Yeah, thank you. The other thing I will say is have a long list of questions, available, because the worst thing that you can do on an interview is the interviewer saying to you, "Do you have any questions for me?" And you're saying, "No." So I think it's really important to have a long list of questions, and some of those questions, so we do a presentation for the first half an hour and talk about the program, do a PowerPoint, and then we leave about 20 minutes after the presentation for them to ask questions. So a number of questions get asked during that time, but then there is, during your one-on-one sessions, there's an opportunity to learn about the program and ask questions. So definitely, having those questions, I think, are, really important. Does anybody else have any other comments or suggestions that, I'm looking for any questions, but I don't see any questions in the chat box. Attendees, if you have any questions, please add them to the chat box. We are happy to answer, but I don't know, Dr. Soto, or Dr. Lendaris, if you have any other advice for applications and interview season.
I think something that I see frequently when I help interviewing residency applicants is that Yeah, what Dr. to say is just like they haven't done the research and they haven't really understand the program that they're applying to. But also, I see very frequently when there is a lot of publications, activities, things that are in the CV, and when we ask them about them, they have no idea what that really is. So sometimes the number of things doesn't really matter, right? It looks bad if the interviewer asks you about a specific activity and then you don't really know what it was. If it's a poster or if there is a publication that you participated on, it's maybe important to say what was your role specifically on it. But I think it does talks about integrity and professionalism. So if you really don't have that in your curriculum, don't mention it. It doesn't look good. So that's something that I see frequently. Just we all want to have a very nice CV that looks bulky, but bulky doesn't make good. So I think it's better to avoid things that are not relevant in your training or you don't really know what it was.
Yes, absolutely. One other piece of advice that I would really like to give this generation specifically, not to judge, is, we're all social media, right? So, please be very careful about the things that you say on social media. Because, I know when we ran the residency program, Dr. Vanino, who was the program director, would go and, specifically look for things. And there is a number of, neurology forums and things like that. And, if people say some really ridiculous things sometimes, and I think it's really important to manage your social media presence. I mean, there are tons of lectures on how you can make social media work for you, right? But at the same time, you want to make sure that you're not having social media work against you, especially political scenario, what's going on in the world. I think it's really important to just kind of like zip up and not get into trouble. Yes, please, Dr. Lindaris, go ahead.
So I just wanted to add too, I think we're talking about basically different aspects of being a medical student, being a person, and I'm forthcoming with my vision and hearing changes, right? So you may have unique things, maybe they're not a sensory or a motor change, but that is another learning curve when you're going from being in a controlled environment, which is a classroom, to a dynamic clinical setting. It's a background learning curve to shift into how am I going to move with this team on rounds? How am I going to go to bedside and do exams? How am I going to look up this information on the EMR, keep up the pace? I just want to acknowledge that that is a separate learning curve that you may be going on for whatever reason. And that depending on schools, there's different resources. If your school in particular does not have a resource where you feel like you can help translate, how am I going to do this neurologic exam when I have this change? And this example I'll just give you is I have line of sight vision, so I don't have periphery. And I've had many residents and attendings ask me, well, how do you do a visual field test? I'm like, well, the joke's on you because I still have proprioception. I know where my joints are in space. Right? So I can still put up my hand and know that my hand is here. I don't see my own hand, but I can still test your visual field because I know you'll tell me how many fingers I'm holding up. But so I don't want anybody out there to be discouraged. If you have a difference and that you need to have a modification, you can still achieve doing clinical exams. So don't be intimidated or have imposter syndrome if you have a difference. Just reach out and there's resources and support.
Yes, absolutely. And so I don't see a lot of questions or any questions in the chat box. Guys, if you have any questions, please go ahead and put the questions in the chat box. We have a few more minutes. And if you don't, then I'm going to turn it over to Lucy.
What's your favorite part about working with residents?
I think we can all talk about it. Why don't we start with Dr. Soto and then we'll go around and...
Yeah, I do love working with residents and medical students. Actually, I think it is mentally stimulating. You gotta be on your toes every single time. You have to be updated. You need to learn, or I like to learn the learning ways that my residents had. Not everybody learns the same way, and it's not the responsibility. I mean, it's a two-way responsibility, but I think it's a responsibility of the teacher to understand how your student, how your learner learns better, and adapt the content that we are delivering to make it effective. So I find it as a challenge for myself, and I'm every single time it's like, okay, this doesn't work for this specific resident. How am I going to help it this other way to understand this concept that is very important to move forward in our careers? So that I enjoy. That is actually the way that I hope my brain will continue to be young and absorb information. It is very stimulating.
Yes, and Dr. Lindaris.
I just want to piggyback on that, right? I think it's loving to learn and just seeing someone else have that aha moment is really my greatest joy, and see that connection and then really be there to deliver the care to the patient and have a patient understand what's happening and feel empowered by what we're doing. All of that collectively makes even the hardest, most tiring days rewarding.
Absolutely. And Dr. Gato?
I feel the same. Yeah, I think I could be doing a much easier job, so somewhere else that's not a part of, teaching. If I just didn't love being around learners. So I think they keep you sharp. And speaking of imposter syndrome, I usually walk in, the first few days of the rotation, wondering when are they going to figure out I don't know anything, and then and then they're teaching me a lot, and there's so many things that so my background is in autoimmune neurology, and I do some clinic or neurosarcoidosis, and then I come in the hospital and I see everything else. So I'm really a general neurologist in the hospital. Strokes and seizures and encephalopathy and immune checkpoint inhibitor problems. We have a big cancer population in Emory, and a whole variety of things. And so residents are oftentimes teaching me something very interesting that they've learned wherever that was, including through some other subspecialty experience. And so I think that's a really, neat and exciting, kind of part about our job.
Absolutely. And I'll say the same thing. I think you definitely feel more challenged. But at the same time, you guys are a little younger than I am, I guess. And, hanging out with younger people makes me, feel younger than I am. So I enjoy that part as well, in addition to the fact that, absolutely love teaching. And but mentorship, I think, is a bi-directional process. We feel like mentorship is like a senior person and a junior person. It's not like that. I think to me, mentorship is a bi-directional process. We teach you from our knowledge and experience, and you teach us as well. So I like to keep it as a bi-directional free flow. That's very helpful. So firstly, thank you, Lucy and AN, for asking me and all of the panelists to be part of this. It's been really great. And I hope that the experience and the answers provided by the faculty were very useful for the attendees. So thanks so much for having us.
Thanks for joining, everybody. Take care.
Thank you so much. Good night.
Hi, thank you. Good
Bye.
night.